Good afternoon, everyone. Thank you for joining us. We know it's deadline day, so we're going to have a smaller group today. But please note that this update webinar is being recorded and will be available on YouTube, probably later on today, if not the beginning of next week. Today we have Julia Ratti, former senator and also the current director of behavioral health at Washoe County Human Services. Is that correct, Julia? Awesome.
That's good.
Fantastic. Thank you, Julia. And she's going to be giving a quick description and update regarding Assembly Bill 380.
Are
All
you
right.
ready?
So first, we're going to open up with a quick disclaimer. So the purpose of this bill update webinar series is to provide information that will help stakeholders keep track of the progress, content, and any changes to active bills in the 83rd or 2025 session of the Nevada Legislature, which relate to behavioral health. The content presented here is for informational and educational purposes only. It is not the intention of the regional behavioral health coordinators, their home agencies, funders, nor respective regional behavioral health policy boards to persuade participants to take action or position on any bill included in this update series. And we're going to go ahead and say that it is also not Julia's intention to persuade anybody's stance or opinion of this bill as well. Some quick housekeeping. Again, this is being recorded. Here's the link to where we are keeping things on YouTube. I will go ahead and drop that in the chat as well. Unless otherwise specified, go ahead and hold questions and comments for the end of the presentation. At the end of the presentation, go ahead and use the raise hand button. There's also a Q&A function, or you can pop them in the chat. I will be monitoring all of those. If I unmute you so that you can speak and ask a question, please be sure to mute yourself again after you're done asking your question. We just want to make sure that we don't have a lot of background noise because that can interfere with other speakers. So I do reserve the right to mute you if you forget to mute yourself. Also, not worried about this group, but please keep all comments, questions, and discussion respectful. I do reserve the right to remove any participants who engage in any subjectively inappropriate or disrespectful conversation or activity during this meeting. And with that, I am going to go ahead and turn it over to Julia. Thank you so much.
Thank you, Valerie. I appreciate the opportunity to talk about this. So first of all, I should just say that this is Assemblywoman Edgeworth's bill. It is definitely a bill that has been worked on by lots of other people besides me. I think I just was well positioned to give you the quick summary. So just wanting to say that I'm speaking for a village on this one. By way of quick background, in the 2021 legislative session, SB 390 was a monster of a bill that included a lot of things all in one bill. The first thing that it did was build out some of the infrastructure and NRS framework that was necessary to support the state's efforts to stand up the crisis response system. The second big thing that it did was it laid out the state's approach to opioid settlement funding. And so it was a big bill. It also included the provisions that allowed for us to implement a fee on phone lines that created the Crisis Response Fund. And so obviously there was a lot of attention to that section of the bill. In that bill, it made it through the legislative session, but there was a mistake. And that mistake was in the definition of how we define mobile crisis teams. What the bill intended to do was to identify the best practice mobile crisis team at the time. This was the recommendation that was coming out of SAMHSA. And so that was a behavioral health professional and a peer, but it also intended to include the kinds of behavioral health mobile crisis teams that existed in the state at the time. And so it intended to include law enforcement and behavioral health professionals. We have most teams in Northern Nevada that meet this model. And it intended to include EMTs or emergency management professionals and behavioral health professionals as a team. There are models in Southern Nevada that currently operate like that. Unfortunately, how the language came out is the red. So I'm going to go ahead and share my screen here. So this is the actual draft of the bill. Valerie, can you see that? Okay.
Yes, we can. Thank you.
Perfect. So the red, that section 2, A, B, and C, lines 8 through 17, are the definitions as they came out in the 2021 session. And what happened is that the first team was correct. It includes a person qualified in the field of behavioral health and the providers of peer recovery services. But the next two teams included law enforcement and behavioral health professional and a peer, or law enforcement, or sorry, emergency medical services, a behavioral health professional and a peer, thus making the requirement that these be three-person teams, which would not be likely to be sustainable. And so all this bill does is get back to the original intent, which is to have some flexibility in the implementation of mobile crisis teams. What's interesting is since that time, SAMHSA has come up with updated guidelines for the crisis response system. And those guidelines do recognize that there are various kinds of teams with various compositions that can be successful in the delivery of mobile crisis. And so now the way it is written, there's one or more persons professionally qualified in the field of behavioral health. That's an essential element of every team. And then that second person could be a law enforcement officer, a provider of emergency medical services, and or person with appropriate expertise in the field of behavioral health. And that has been brought in to include community health workers, case managers, peer recovery support specialists. So what this does is give quite a bit of flexibility, recognizes the new guidelines that come out from SAMHSA, and hopefully creates a situation where different kinds of communities across our state can have success in setting up different kinds of mobile crisis response models. It's important at this time because the Department of Public and Behavioral Health is working on the regulations to credential mobile crisis teams, and the Medicaid team is working on updated Medicaid billing standards or rates for mobile crisis teams. And with this definition not being correct in the law, that was creating a bit of a barrier. The rest of the bill is just some definitions. So I think I will just stop there and say that it's basically a simple cleanup bill that gives our state more flexibility in the implementation of mobile crisis teams to support the crisis response system. With that, Valerie, if anybody has any questions, I'm happy to answer them.
Fantastic. Okay, so go ahead and use either the raise hand function or you can drop your question into the Q&A, whichever would work best. While we've got some folks who may be working on that, one quick question that I have. So in a lot of our rural and frontier communities, we have what's called most like. And so there may be a law enforcement officer or someone who is a part of law enforcement who maybe isn't a uniformed officer or isn't in a bulletproof vest every day, who is working with, for example, a community health worker or a certified peer recovery support specialist, and they are providing some of these services. Would that type of team fall under this definition that you're aware of?
So I didn't quite get who the first person was. So they're not a law enforcement officer, but they're employed by a law enforcement agency.
Yeah, so they may be a law enforcement officer. I've heard of some where they're thinking about, and I don't think anybody's actually done this yet, but using like the VIPs, so like the volunteers, or using law enforcement, the actual uniformed officers, depending on the jurisdiction. I know that there are active teams that obviously do use law enforcement and then a CHW or peer. Would this definition from this bill cover those teams that maybe do not have access to a clinician directly? And are using a CHW or peer as well?
I don't think it would, because the first, that line 18, that requires that one or more persons professionally qualified in the field of behavioral health. The bill goes on to say that the existing law says that the state will write regulations, if you look up on line 3, defining the term person professionally qualified in the field of behavioral health. So it's really a good follow-up question for DPBH, but I think the intent is that those are licensed clinicians. So I don't think a model that doesn't include a licensed clinician would be included. And so if that's a concern that certain communities have, they should get that to Assemblywoman Edgeworth so she could contemplate that moving forward through the rest of the legislative session.
Awesome. Thank you. Anybody else? Any other questions? All right. Well, hearing none, Julia, is there an email that you'd like to share that people can reach out to you, or should we just have all questions about the bill go to Assemblywoman Edgeworth, or?
Yep, I really think they should go to Assemblywoman Edgeworth. It has statewide implications. I know that it meets the needs for Washoe County, but that doesn't necessarily mean that it meets the needs for the rest of the state. And so, and and of course, based on how quickly the session moves from this point, today, of course, is deadline day for first committee passage, and it just gets faster after that day. So I think if people have concerns, their best course of action is directly reaching out to Assemblywoman Edgeworth.
Excellent. Thank you so much, Julia. Well, we hope that you have a lovely day. Thank you so much for your time and your expertise. And we will hopefully see everyone at a future webinar. Have a great day, everyone.
Thanks, Valerie, for your work on these.
Of course. Thank you.